Adolescence is defined as beginning at ages 11 to 12 years of age and has a variable at 18 to 21 years of age. During this period of time, there are a large number of physical and psychological changes occurring in the boy and girl. Pubertal development is complete by the end of this. Somatic growth is complete because epiphyses have changed. This is a time of remarkable behavioral changes, and sometimes these lead to emotional problems. The adolescent goes through a significant period of social, cognitive, and emotional changes in their development. And with respect to all of this, during adolescence, there's a significant increased risk of mortality and morbidities. Before we get into the rest of adolescent development, let's just briefly review the sexual maturity rating scales in terms of pubertal advancement. This is otherwise known as the Tanner scales. First, in boys, in going from a Tanner 1 or sexual maturity rating 1 through 5, which is the adult appearance, you can see that the features that are incorporated within the rating scales are the amount and appearance of pubic hair, the appearance and coloration of the scrotum, and the size of the testes and the penis. In girls, going from a sexual maturity rating or Tanner scale 1 through 5, the adult appearance, again, like in boys, the feature is the appearance and amount of sexual hair and the appearance and development of the breast with respect to the breast itself, the areola, papilla, and the nipple projection. Early adolescence is defined as 11 to 14 years of age. During this period of time, the sexual maturity rating scales, that is the Tanner stages, are Tanner stage 1 and 2. Females have growth spurts about 6 to 12 months prior to menarche, boys slightly later, with an increased peak growth velocity 2 to 3 years after girls, and therefore continued growth for 2 to 3 years after girls have stopped. There are gender-specific changes in mean body fat and lean body mass. With respect to cognitive development, there's rapid cognition development, specifically a transition from concrete operational thinking to logical, abstract, and idealistic thinking. Self-awareness increases, mostly with respect to external characteristics. With respect to psychosocial development, the main features are primary interest with peers of the same sex over family. The adolescent at this stage has an increasing desire for autonomy, independence, and privacy, and expresses the developing sense of personal identity. Development of adult relationships occur other than parents as their role models. And the big part of this phase is the significant adjustment to middle school, which is more challenging in terms of the social environment, and with this is a development of a sense of achievement and self-esteem. Mood swings are common, and attempts at independence, both of which may lead to arguments with parents. In terms of sexual development, during this phase, there's increasing anxiety and interest in sexuality, the beginning of consolidation of sexual orientation, individual and mutual sexual exploration, and the most common form of sexual behavior is masturbation. Middle adolescence is defined as being between 15 and 17 years. During this period, growth accelerates, stopping at about 16 years for girls, 18 years in boys. Weight parallels height, muscle mass and strength increase, lean body mass increases in boys and decreases in girls, with accumulation of subcutaneous body fat. During this time, the adolescent is typically at sexual maturity rating scales of 3 and 4, where menarche is reached in almost all girls. In terms of cognitive development, the main issue during these years is the development of formal operations, that is, further development of logical and abstract thought, complex reasoning, inductive and deductive reasoning, inferential thinking, and moral thinking. They gain the ability to understand actions in a moral and ethical sense with the development of a personal code of ethics. From a psychosocial standpoint, peers are the key reference group for developing important behaviors, with further separation from the family. This may involve possible strained relationship. Their driving force is increased freedom and unsupervised time. The central focus in their lives is school and related activities. Appearance remains important, but adolescents become more accepting in general of their body image. They have an increased experimentation with risky behaviors. They become more introspective, idealistic, and have concern for the future and available opportunities. This is the time of the highest risk of mental health problems, such as mood disorders, conduct disorders, and learning disorders. With respect to sexual development, at this time is sorting out of sexual identity, experimentation, dating and superficial relationships. Sexual knowledge and risk do not always control their behavior. Sexual activity is highly variable from one adolescent to another. Late adolescence is 18 to 21 years of age. This is now the sexual maturity rating scale of 5, the full adult tenor stage. There's also growth of facial and chest hair, and may even have the onset of male pattern baldness at this time. Physical development is complete. Linear growth has ended in males. With respect to cognitive development, the cognitive skills continue to develop with now full independent analysis of situations, events, mores, and ethics. There's a sense of self-identity with refinement of the value system and more thinking about perspectives for the future. With respect to psychosocial development, there is increased thoughts about others, decreased adult supervision with increasing autonomy and eventual emancipation, emotional and physical separation from the family, increasing stress and relationships may lead to experimentation with drugs and alcohol, peer groups and values become less important, emotions are steadier and more constant. And finally, with respect to sexual development, empathy develops in that there's a need for meaningful relationships, capacity to commit to some form of relationship. More serious relationships develop involving love and commitment, and at this time is consolidation of sexual identity. A 16-year-old girl presents to her physician because of fever, chills, pain, and swelling in the small joints of her hands, and macular papular rash on her upper and lower extremities. This next section will be a brief review of the most common organisms causing sexually transmitted diseases in adolescents. Otherwise, this will be covered more fully in obstetrics and gynecology. The first is gonorrhea, where the etiology is Neisseria gonorrhea. This can present with male urethritis, which is the presentation being urethral discharge and or dysuria. However, most males are asymptomatic or have minimal symptoms. The other common organism presenting like this in males is Chlamydia trachomatis. If it is in these two organisms, then much less commonly we may have ureaplasma ureolyticum or mycoplasma genitalium. Cervicitis is the presentation in girls. These are deeper infections within the cervix, and the presentation may be with irregular or increased bleeding, mucopurulent discharge, or erythematous cervix that bleeds easily. Besides Neisseria gonorrhea, again, the other major organism presenting in this way is Chlamydia trachomatis. Pelvic inflammatory disease may be the worst presentation. This is upper genital tract infections causing endometritis, salpingitis, tubo-ovarian abscess, and even pelvic peritonitis. Again, besides Neisseria gonorrhea, Chlamydia trachomatis is the other most common, particularly with younger adolescents. However, with aging and recurrence, there's an increased incidence of Mycoplasma hominis, group B strep, other streptococci, anaerobes, E. coli, and Gardnerella vaginalis. Diagnosis is made by culturing any discharge from the urethra, from the cervix, and sending this for gram stain, culture, and sensitivity, and doing PCR in terms of finding most readily Chlamydia trachomatis. If Neisseria chlamydia is not found, then the organism secondarily is most commonly ureaplasma ureolyticum or mycoplasma genitalium. Because there are no diagnostic tests that are easily available for these organisms, they then typically would be labeled as non-gonococcal, non-chlamydial urethritis. Empiric treatment with either ceftriaxone or azithromycin is initiated if any of the primary signs are present. The partner is treated as well, and further workup includes looking for any other possible sexually transmitted diseases. A 16-year-old boy presents to the emergency center with a persistent penile discharge. The patient states that 1 week ago he saw his family physician for this same problem. At that time, the physician gave him an intramuscular shot of penicillin. However, the patient states that the discharge did not resolve with the penicillin. He would like a second opinion. Chlamydia is the most common sexually transmitted disease in developed countries. We basically talked about the presentation often being very similar to that of Neisseria gonorrhea. Like with Neisseria, there's a mucopurulent discharge. We may also have the presentation of lymphogranuloma venereum. Diagnosis, as stated previously, is with PCR, that is nucleic acid amplification. Chlamydia is not easily cultured, and so this typically is negative, including the gram stain. Treatment very specifically is azithromycin or doxycycline for 7 days, erythromycin if an adolescent girl is pregnant. A 15-year-old presents to her physician because she has a yellow, foul-smelling vaginal discharge. On physical exam, she is noted to have a strawberry cervix. The vignette describes a case of trichomoniasis caused by trichomonas, of course. This is one of the most common causes of a vaginitis, which represents superficial infections of the vaginal mucosa. There can be vaginal discharge with or without vulvar inflammation, pruritus, and odor. Trichomoniasis is not typically an STD, but there is increased incidence with sexual activity. Besides trichomoniasis, candidiasis can look like this as well. Females typically who present with this on inspection have a strawberry-like appearing cervix. Males are frequently asymptomatic. The best initial diagnosis is with a wet prep, where we should see the motile protozoans with this. In addition, other clues are gray-yellow discharge with a pH of 4.5 and a positive amine odor. Also, on microscopic examination, we can see white blood cells. The best test is culture, and treatment is with either metronidazole or tinidazole. A 17-year-old sexually active boy presents to the physician because of painful ulcerations on his glans penis and on the shaft of his penis. He has multiple sexual partners, does not use condoms. A fever and inguinaloadenopathy are also present. The vignette is a case of herpes type 2. Herpes 1 causes non-genital infections of the mouth, the eye, and the lips. Type 2, genital infections, oral infections, and of course it can be transmitted during the intrapartum period to the neonate. The key is finding ulcerative lesions exposed to sexual contact, most on the penis and the vulva. We can also have oral rectal lesions. And if this is the case, herpes is going to be primarily the causative lesion. Much less commonly would be syphilis and chancroid. Initial screening tests with Sank's preparation can be done. Serological testing with ELISA, and of course, any fluid from the ulcers or vesicles can be tested with polymerase chain reaction. Treatment is with either acyclovir, valacyclovir, or famciclovir. Mother brings her 15-year-old daughter to the dermatologist because she has developed pimples. The mother says that her daughter's face breaks out because she drinks soda pop. The daughter is argumentative about this, but admits that she does drink soda pop every day at lunch. The mother would like you to tell her daughter to stop drinking soda pop. On physical examination, the patient has open and closed comedones and pimples on her forehead, nose, and cheeks. Increased adrenal androgens at puberty typically leads to abnormal keratinization of follicular epithelium with impaction of keratinized cells within the follicular lumen. Plus, there is increased activity of sebaceous production of sebum and proliferation of the bacterium called Propionibacterium acnes, which leads to increased formation of free fatty acids by hydrolyzation of sebum triglycerides, which brings on the inflammatory reaction. There are three major types of lesions that we see in adolescents with acne. The first are comedones. These are non-inflammatory lesions from dilated epithelial-lined follicular sacs filled with keratinous material, lipid, and bacteria. The open comedone is called a blackhead and has a pilosebaceous opening where a plug may be seen. In the closed comedone, which is called a whitehead, there's a very small opening that becomes inflammatory and occurs much more easily than an open comedone. Inflammatory papules or deeper nodules develop from a comedone that's ruptured its contents into the dermis and has led to an inflammatory response. If the inflammation is close to the surface, it results in a papule or a pustule. If it's deeper, a nodule develops. And finally, nodular cystic lesions are liquefied masses of inflammatory debris which form from suppuration and giant cell reaction to keratin and hair. Mild acne consists mostly of open and closed comedones with a few small papules and pustules, which occur mostly on the central part of the face. Primary therapy is with a topical retinoid that can be applied once nightly. They come in various strengths, and we typically start with a low strength and gradually increase this as tolerated. The various retinoids that are used are primarily three: tretinoin, adaptoline, and azelaic acid. Tretinoin and adaptoline are basically anti-comedonal, anti-inflammatory, and keratolytic. The main side effects are irritation and dryness. Azelaic acid has mild antimicrobial and keratolytic action. The important point is to allow at least 4 to 8 weeks before assessing the effect. Moderate acne is increased numbers of comedones, papules, and pustules with a greater spread, typically over the upper chest, the deltoid, and the upper back. And there are three treatment modalities: topical retinoid plus benzoyl peroxide once or twice daily. The benzoyl peroxide, for instance, may be used in the morning, the topical retinoid at night. Benzoyl peroxide is mainly an antimicrobial, and its main side effect is irritation and drying. Clindamycin or erythromycin, used as topical antibiotics, are typically used in combination with benzoyl peroxide. They are more effective And in addition to that, because they are not anti-comedonal and may lead to resistance, we don't typically use these two topical antibiotics by themselves. They, again, are primarily for inflammatory acne, or we can use an oral antibiotic if there's no response to the topical therapy alone, or if the topical therapy is not tolerated, or with moderate to severe inflammatory disease. It's given once or twice daily for at least 6 to 8 weeks, followed by a decrease to the minimal effective doses. Again, the antibiotics that are used orally this time are tetracycline or one of its derivatives, particularly doxycycline or minocycline, or we can use oral erythromycin. They decrease the growth and activity of P. acnes and are anti-inflammatory, but again should never be used in combination with topical antibiotics due to possible resistance and side effects. Stepping up slightly from mild to moderately severe to strictly moderately severe acne, the major difference is there are many comedones, papules, and pustules with a few deeper inflamed nodules and more extensive involvement of the trunk and the shoulders. Basically, there are two treatment options. The first is topical retinoid plus benzoyl peroxide plus an oral antibiotic, or the use of isotretinoin, of which the brand name is Accutane, if there's no response to conventional therapy. Now, isotretinoin is 13-cis-retinoic acid, and the standard oral course is 16 to 20 weeks, and there may be additional courses depending on how well it works. It has keratolytic effects, anti-inflammatory effects, reduces P. acnes, is anti-comedonal, and decreases sebum. However, remember it is teratogenic, and therefore the patient must adhere to a pregnancy prevention program with the use of a signed statement, birth control, and pregnancy monitoring. Also, prior to starting the drug, we have to rule out liver disease and hyperlipidemia and recheck the labs in 4 weeks, because we may see an increase in serum triglycerides and cholesterol, and there may be other side effects as well. And finally, for those with severe acne, this consists of nodulocystic acne, many small papules, pustules, comedones, plus large numbers of deep, painful nodules and cysts on the face and the upper trunk with more widespread involvement of the trunk and the shoulders. The treatment is basically the same as moderately severe acne, that is topical retinoid plus benzoyl peroxide plus an oral antibiotic, and more of these patients are most likely going to have a trial of isotretinoin. Now, in addition to the isotretinoin, because of the often painful nodulocystic lesions that are involved, intralesional corticosteroid injections directly into the lesion may be needed. And in the worst cases, we should consider hormonal agents, that is, estrogen-containing oral contraceptives, or even spironolactone for women who are unresponsive to antibiotics and are not candidates for whatever reason for isotretinoin.